Today we have a PG topic by Dr. Navina, Junior Resident, KMCT Medical College, and a video session by Dr. Shailesh, a laparoscopic spleen and vessel preserving distal pancreatectomy. And the main topic is by Dr. Pradhaban VK, demystifying pancreatic cyst lesions, diagnostic approaches and therapeutic considerations. And Dr. Shailesh and Dr. Pradhaban doesn't require any introduction, and therefore we will directly go to the minutes of the previous meeting.
Last meeting was held on February 8th at Tripanda. There is a long duration of nearly 1.5 months. Actually, we didn't plan to have any meeting till Calicut. By that time, Sun Pharma came. They told they will do a meeting for us. Then I happily accepted. The previous meeting was held on 8th at February at Tripanda. It started with a silent prayer and a PG topic discussion by Dr. Jean from Malabar Medical College. Then it was a liver cyst de-roofing surgery. And the main topic was by Dr. Sandeep Naik. He presented about current and future scopes of robotic surgery. The meeting was well attended, nearly 126 people attended. The active discussion went, and after that, inspired by his talk, 3 of our residents went to Bangalore to observe the robotic. The meeting concluded after national anthem, followed by a dinner. Can the minutes be passed? So I think without much waste of time, we will start the session for today. I invite Dr. Navina to start the case presentation.
Good evening, everyone. Beyond the swell, unraveling thyroid secret ties to colonic cancer. I myself, Dr. Navina, Junior Resident, KMCT Medical College, here to present an interesting case of thyroid swelling. Coming into the history of presentation, presenting the case of Ms. X, 19-year-old female patient hailing from Anakamboil, Kozhikode district. She's a second-year BSc nursing student at Mysore. She presented with complaints of swelling in front of the neck for past 1 year. History of wrestling illness. Patient was apparently normal 1 year back when she noticed a swelling in front of her neck, which was initially small in size and gradually increased to present size over past 1 year. No history of rapid increase in size, fever or pain. No history of any pressure symptoms, features suggestive of hyper or hypothyroidism, significant weight gain or weight loss, menstrual irregularities, alteration of bowel habits and all. No history of any other swelling elsewhere in the body. No history of taking any medications for the same complaint. No history of back pain, bony swelling, long bone pain, hemoptysis or jaundice. Going on to the past history, no history of similar illness in the past, no history of taking any medications for the same, no history of any other comorbidities or prior surgeries or drug allergy, no history of any prior radiation exposure. On to the personal history, she's taking non-vegetarian diet, her sleep and appetite were normal, bowel and bladder habits were normal, no addictions or no history of any allergies. Menstrual history, menarche at the age of 13 years with 28 to 34 days regular cycles and no history of any menstrual abnormalities till date. An important family history, history of thyroid illness in her mother, for which she underwent total thyroidectomy 25 years back at a young age, and HPE report is not available. And history of adenocarcinoma rectum in mother's sister, for which she underwent chemo radiation recently from MVR Cancer Center. Moving on to examination. General examination, patient was examined in a well-lit room with adequate exposure after getting informed consent. Patient was conscious and oriented, poorly built and nourished, with a BMI of 70 kg per meter square. And Karnofsky performance score was 100. There was no pallor, icterus, clubbing, cyanosis, lymphadenopathy, no evidence of edema. Skull and spine was grossly normal. Skin and appendages were normal. No features suggestive of MEN1 or MEN2 syndrome. And on to vitals, pulse rate was normal and rest of the vitals were normal and no evidence of any tremor. And systemic examination were within the normal limits only. Then local examination. On inspection, a butterfly-shaped swelling noted over the anterior aspect of neck, nearly 4 into 4 centimeter, which moves with deglutition. Skin over the swelling appears normal, and no dilated veins, scars, or sinuses noted. Surface was, appears smooth, and lower border was visible. Pemberton sign negative, trail sign negative. On palpation, there was no local rise of temperature or tenderness. Swelling was of size 5 into 5 centimeter, moving with deglutition, and had intrinsic mobility. Surface was bosselated with multiple nodules, palpable over both sides of neck, with a firm nodule over right upper pole, and lower border was palpable. And extends superiorly, it reaches up to the level of thyroid cartilage, and inferiorly 2 centimeter above the level of suprasternal notch, and laterally 2 centimeter bilaterally from midline. And trachea was central, Koch's text was negative, and Bury sign was negative. No palpable cervical node was noted. On percussion over manubrium sternum, it was resonant, and on auscultation, no thyroid bruit was noted. Regional lymph node examination, no cervical node enlargement was noted. Summarizing the clinical history, a 19-year-old female patient with complaints of swelling in front of her neck since past 1 year, which gradually progressed in size over past 1 year, and no feature suggestive of hyper or hypothyroidism pressure symptoms. But there was a history of thyroid illness in her mother, for which she underwent total thyroidectomy at a young age, and history of adenocarcinoma rectum in patient's mother's sisters, for which she underwent chemoradiation recently. And on examination, a butterfly-shaped swelling noted over anterior aspect of neck, nearly 5 into 5 centimeter, which moves with deglutition, and there was no palpable cervical lymph nodes. Then we evaluated with by running a TFT, which was within the normal limits. Proceeded with the ultrasound, and it shows features suggestive of multinodular goiter only. Then the FNAC came. In this, from right side, the FNAC shows papilleroid clusters with occasional nuclear features suspicious of malignancy, and left side shows benign follicular nodule, Bethesda category 2. And after PAC clearance and ENT evaluation, she underwent total thyroidectomy under GA. And intraoperative findings were enlarged both lobes and isthmus of thyroid, multiple nodules over both lobes, and largest over right lobe, firm to hard in consistency. And postoperative period was uneventful. Then on the histopathological examination, as you can see in the figure, papillary and cribriform pattern are seen, along with features suggestive of papillary carcinoma thyroid. In papillary carcinoma thyroid, there will be nuclear overlapping, crowding, and nuclear clearing. And here specific features include morules. There's whorls of spindle cells arranged in a eddy pattern. This is called morules, and cribriform pattern is shown in the first figure. This gives a histological diagnosis of cribriform morular papillary carcinoma thyroid, which is a new entity. Until 2022, it was WHO edition 4 classification of thyroid tumors. It was considered as a variant of papillary carcinoma thyroid, and on 2002, when WHO 5th edition was published, it is considered now as a separate entity as a cribriform thyroid carcinoma under thyroid tumors of uncertain histogenesis. This is a 5th edition classification of thyroid tumors. And as we expected, IHC was done, and beta-catenin was positive, which indicates cribriform component of the specific type of cancer. Briefing a bit about cribriform morular thyroid carcinoma. It's an uncommon thyroid neoplasm, accounts for about 0.2% of all papillary carcinoma thyroid, and almost exclusively occurs in females, and mean age is 26 to 33 years, and more common in Asian population, and first reported case was in 1990. This carcinoma has low incidence of lymph node metastasis and cancer recurrences. And the most important thing is that it's nearly 40% of the diagnosed cases have familial adenomatous polyposis, which is a precursor of colonic malignancy. So we proceeded with colonoscopic evaluation of the patient, and we noticed numerous polyps over colon. And likely diagnosis was familial adenomatous polyposis, which was confirmed by HP biopsy. And this occurs due to sporadic or genetic mutation on APC gene and resulting in the activation of WNT beta-catenin signaling pathway, leading to accumulation of beta-catenin in the cytoplasm. And aggressive features include neuroendocrine differentiation, necrosis, and increased mitotic activity. And the prognostic factors include general indolent clinical course with a good prognosis, but some aggressive cases have been reported. And lymph node metastasis at presentation include 5 to 12% of the diagnosed cases. And distant metastasis in 3 to 6% of cases, and overall mortality accounts for about 2%. Cribriform morular thyroid carcinoma can show a high Ki-67 labeling index despite its excellent prognosis. And coming to the treatment, lobectomy is recommended for non-FAP associated cribriform morular thyroid carcinoma and total thyroidectomy for FAP associated cribriform morular thyroid carcinoma. Extensive lymph node dissection is not necessary because of the nodal metastases are rare. And lack of follicular differentiation raises the possibility that these tumors may not benefit from radioactive iodine therapy. In cases with recurrences or distant metastasis may respond to lenvatinib, and clinicians should be alert to exclude FAP, since this diagnosis is the first indicator of FAP syndrome in 25% of cases.
Thank you, Dr. Navina. That was a good presentation for discussion.
The relative who had colon carcinoma, she also had FAP.
Yes, sir.
She had FAP.
കോളൻ ഹിസ്റ്ററി പറയുന്നില്ല, പക്ഷേ CA റെക്റ്റമാണ് ഇപ്പോൾ ഡയഗ്നോസ് ചെയ്തിട്ടുള്ളത്. അതിന് കീമോ റേഡിയേഷൻ പോകുന്നുണ്ട്. അതിൻ്റെ കൊളോണോസ്കോപ്പിക് ഇവാലുവേഷൻ്റെ ഡീറ്റെയിൽസ് കിട്ടിയിട്ടുണ്ടായിരുന്നില്ല സർ. ബയോപ്സി വിട്ടപ്പോൾ ഇതുണ്ടായിരുന്നു.
This case is presented only because now consider a rare separate entity by the WHO. Otherwise, to us considered as a cribriform papillary thyroid carcinoma and is strongly associated with FAP.
Actually, I was evaluating a patient with FAP for surgery. So the anesthetist identified a thyroid swelling, and she has papillary carcinoma. I think she undergo papillary carcinoma surgery first and FAP no adenocarcinoma. But she is around 35-38 years. It's late presentation of FAP actually. I think thyroid carcinomas are seen in patients with FAP. I have seen 2 or 3 patients previously.
Rectum, CA rectum. Colonoscopic biopsy was taken and it was adenocarcinoma rectum. Polypoid lesions was not noted in that colonoscopic report. Yes, she's alive. She underwent chemoradiation therapy from MBR.
She is asymptomatic now. So, no symptoms now.
She's on ongoing therapy. FNAC diagnosis will be difficult because of the architecture. Mottam kandale it will be. Yes, sir. I think it might help. Lobectomy. Yes, sir. 40% of patients with cribriform morular thyroid carcinoma will 25% of FFP will be having cribriform morular thyroid carcinoma, study says.
Radioiodine scanning?
This patient underwent radioiodine therapy.
Scanning you are done?
Yes, sir. First indicator will be a thyroid swelling.
That I agree, but I don't think that carcinoma thyroid incidence is not that what is the role of doing this for prophylactic anyway 25% to develop thyroid tablets. We have to do prophylactic surgery of individual organ which develop cancer.
In an article, sir.
That is the reverse. 25% of switching from modular carcinoma will be related to FFP. That will make it 40%.
Thank you, everyone.
Now, I invite Dr. Shailesh Calicut for his video presentation on spleen and vessel preserving pancreatitis.
Respected teachers, my dear friends and colleagues, good evening to all. As outset, I would like to thank the office bearers of Calicut Surgical Club, Dr. Unais, especially Dr. Unais and Divin, for giving me this opportunity to present this topic here. This is a video presentation, laparoscopic spleen and vessel preserving distal pancreatectomy, how I do it. So we know there are actually basically three types of distal pancreatectomy. The classical distal pancreatectomy with splenectomy that most of we do for malignancy. It is a radical procedure. This can be different types of distal splenectomy like antegrade, retrograde. And second one is spleen and vessel preserving distal pancreatectomy. It is usually indicated for benign lesions of pancreas, especially if it is in the body and tail of pancreas. Difference here is pancreas is transected and it is antegrade dissection from the neck to the tail, and the vessels are preserved. Spleen is also preserved. This is called Kimura technique. And there is another type of spleen preserving distal pancreatectomy that is called Warsaw technique, in which we will resect the vessels and also the tail of pancreas. The blood supply to the spleen comes from the left gastroepiploic vessel. So even if we resect splenic artery and vein, you can still preserve spleen. That is called Warsaw technique or spleen preserving distal pancreatectomy. This is my port position and OT setup. A camera port is placed here. That is the umbilical port, that is 11 millimeter camera port. And then one right hand working port in the right midclavicular line, and left hand working port in the left midclavicular line. And one 5 mm port, that is 5 mm port, that is retracting port, that is in the close to the siphisternum. There also one retracting port in the left side, that is in the anterior axial line. And patient is placed in lithotomy position, that is split leg position, and surgeon stands in between the legs, and camera assistant stands to the left of the surgeon, and nurse stands here, and assistant also stands here. This case actually a 15-year-old girl with a 5 centimeter cystic neoplasm in the posterior aspect of the body of pancreas. These are steps. Actually, there are 7 steps. One is exposure of pancreas by dividing the gastrocolic omentum, and then separation of the splenic vein from the body and neck of pancreas. Then separation of splenic artery and hepatic artery. Then transection of pancreas. Next step is splenic vein and artery from the tail of pancreas separated by ligating individual vessels from the splenic vein and artery. And then specimen extraction is by extending by umbilical port or by fan shield incision, and then a drain is placed. Coming to the video. Here I am dividing the gastrocolic omentum to expose pancreas. Here you can see my left hand working board is holding the omentum, and right side there is right hand I have got a harmonic scalpel, and the pancreas exposed, so you can see the cystic neoplasm in the body of pancreas there. And the entire pancreas up to the tail is exposed. And then the inferior part of the pancreas is dissected. The idea is to locate the portal vein or splenic vein joining the portal vein. Usually, when you dissect in the body, you will directly go to the plane that is posterior to the splenic vein, because splenic vein will be completely inside the pancreas in the body region. But if you go to the neck, you will get some plane between the portal vein and the pancreas. Here this is a cystic tumor, and the inferior part is generally dissected. And I am coming to the neck of the pancreas. Dissection is joined to the neck of the pancreas, where you can see there is a plane between the splenic vein and the pancreas. Here the plane is dissected. This plane I dissected usually goes to just posterior to the splenic vein. This is called the Toll's fascia. That is a fascia that is covering splenic vein and pancreas. So you have to divide the Toll's fascia and separate splenic vein from the pancreas. Here I am dissecting anterior to the splenic vein. And here on the left side we have portal vein. This is a splenic vein. So this splenic vein is completely inside the, usually it will be completely inside the pancreas in the body region. Then dissection is turned to the superior after the pancreas to identify the hepatic artery and the splenic vein. Hepatic artery and the splenic artery. The lymph nodes that is over the hepatic artery and splenic artery will have to be removed to skeletonize a vessel. And that lymph node is removed, and then this artery, splenic artery, is hooked and separated from the pancreas, body of the pancreas. Splenic artery will be just superior to the body of the pancreas. When you come to the neck of the pancreas, it will be hepatic artery. So this I hooked the splenic artery, and it is kept into inside a vessel loop. Then dissection is again carried to the lower part of the inferior aspect of the pancreas, and the dissection is done between the splenic vein and the pancreas. There will be small individual vessels that is going into the pancreas that should be individually clipped and divided. Here there is some sclerotic reaction to the additions because it's a maybe long-standing tumor. Some pressure effect is there, but splenic vein is not infiltrated. So this surgery was done in 2016. Now it is an 8-year-old video. And here you can see it is generally, slowly we are dissecting the splenic vein from the pancreas. Then splenic vein is transected. This pancreas, neck of pancreas is transected. And most of the cases I use a white cartridge for transecting the pancreas. If it is too thick, we will have to go for a blue cartridge. It is just at the neck, it is transected. So it should be, you have to take around 2 to 3 minutes to, I usually take 2 to 3 minutes to transect neck. Very slowly it is engaged and compressed and slowly transected. And once this transection, then this is transected, check for hemostasis. And usually I don't oversew the pancreatic stump. Then the dissection proceeds to the body and tail of the pancreas. Usually splenic artery will be little more away from the, so it is never a problem. Controlling splenic artery is never a problem, but main problem is with controlling the splenic vein. It may be very densely adherent, very close to the pancreas. Here, especially as the tumor is on the posterior aspect, it is very close to the splenic vein. And there will be multiple vessels going into the tail of the pancreas. So it has to be individually identified, clipped, and divided. Most of the dissection is done with these two instruments. That is, in the left hand there is a dissecting, so on the right side there is a harmonic or other dissecting instruments. And when it goes close to the tail, it will be easier. Main difficulty is in the body region. So dissection is proceeded on the tail of the pancreas and the specimen is removed and a drain is placed into close to the transected pancreas. So in the last 5 years, I just reviewed the cases in our department. We had 36 cases of cystic neoplasm of pancreas. And out of this, most common was mucinous cystoma, 28%, as PEN was 22%, and then IPM and serous. And most common procedure that we do was distal pancreatomy for cystic neoplasm, 72%. Out of this, we did 26 cases, 18 spleen preserving, and 8 cases we had to resect the spleen. And we pulled 6 cases, and central pancreatomy 3 cases, and total pancreatomy 1 case. Thank you.
Thank you, Dr. Shailesh. The topic is open for discussion.
Yes, usually, yes. In all cases, we will attempt a spleen and vessel preserving distal pancreatomy in all cases. But intraoperatively, in some cases, we will have to convert. There will be some bleeding. And in that case, we will just ligate the splenic vein and then make it convert into the Warsaw procedure. It is around 70% this vessel preserving, 1/3 to 2/3. In 1/3 case, intraoperatively, there will be some problem, some bleeding. Then anyway, you can convert because you have to preserve the left gastroepiploic artery and vein. Before that, you can clip again the splenic vein and then you can resect preserving the spleen you can. That's not required. That is not required. So if it is in a lesion located in the tail, then we can resect only the tail, that much margin. that area you can dissect. It's slightly difficult to locate the portal vein there. That is correct, splenic vein. Going to the tail, it will be much easier. Neck also it is easier. In the body part, it will be difficult. So neck, in the tail region, we have done many cases like that. We can preserve, no problem. No need. This here the lesion was bigger. It was here our difficulty was whether to do a central. Yes, there is spen. Diagnosis it is spen. Histopathology is spen. The patient is still under follow-up. No.
If the spleen is viable with the short gastric vessels, why can't you just divide the the splenic vein, and it is an easy procedure, right?
Yes, that is an easy procedure. But thing is that there is a lot of studies comparing this version, and this problem is with the left-sided portal hypertension can be slightly more in this type of patient. That is a theoretical possibility only. So a lot of studies in original publications also show that there is a subclinical left-sided portal hypertension. There is no bleeding, nothing, but it is described that there can be some patients can develop a subclinical left-sided portal hypertension. So it is better always, if possible, preserve the splenic vein.
Thank you, Dr. Shailesh. Now I invite Dr. V.K. Prathapan to speak on the pancreatic cyst. Dr. Prathapan, he requires an introduction, but not to this audience. And, the surgical club believes that he has been introduced to the possible extent. So, please.
So, why this topic? I think we are using AI for selecting topics. So when Dr. Dibin asked me to give a talk, I just checked in AI and I got a topic like that. First of all, I thank the organizers of Calicut Surgical Club for giving me this opportunity. It's a pleasurable moment to see my teachers, all teachers, starting from Rajan sir, Nirmal Rasalam sir, and our recently retired Gobi sir and all. So my area of interest is actually pancreatic surgery, and that's why I selected this topic. So cystic neoplasm of pancreas is a very common problem when you do investigation for some other disease. It's a very frequent practice to send for ultrasound whenever there is a mild abdominal discomfort, or even for a uterine problem, they do ultrasound and they will identify some lesion in the pancreas, and then starts the real issue. So it's a frequent encounter on imaging, and it represents less than 10% of all pancreatic neoplasm. It can have varied clinical and imaging presentation, and there is a wide range of prognostic and treatment implications. Sometimes it may be entirely benign, and the other will be rapidly progressing and aggressive type of lesion. But most of the time, the imaging helps you to identify the type of lesion, but minority remains indeterminate. So these are the different types of lesions which you identify on imaging, and they are differently divided, termed as microcystic, macrocystic, etc. I will come to it later. So basically, pancreatic cystic lesions can be classified based on whether they are epithelial or non-epithelial, whether they are neoplastic or non-neoplastic. So the most common lesion will be a non-neoplastic pancreatic pseudocyst, which occurs after an episode of pancreatitis, either acute or chronic or a trauma. The other type of cystic lesions are all epithelial lesions, where they have a epithelial lining, which ranges from a malignant variant to a benign variant. The malignant variant include the mucinous type of lesions and the solid pseudopapillary epithelial neoplasm, whereas the benign tumor include the serous cystic neoplasm and the small type of IPMNs. So 2.6% of all abdominal multi-detector CT will detect these type of cystic lesions, And when you do MR, it may range to 20%. And if you do the imaging in an older individual, the range may be up to 40%. So when you see these lesions, the key issues to be addressed, one is to differentiate it a cystic lesion, whether it is a cystic neoplasm or a pseudocyst. And when you have identified a lesion, what will be the next investigation modality? Whether you go for a CT, whether you require MR, or whether you opt for a US. Definitely there is a role for endoscopic ultrasound in managing these type of lesions. You have to predict the malignant behavior of the lesion from the available imaging modalities, and whether you require surgery in all lesions or whether you can manage them or keep under follow-up for long, and how to manage an incidental cyst and what will be the follow-up pattern. So these are the different demographic and clinical features of pancreatic cystic neoplasm, and you can see the serous cystic neoplasm. Actually, they are seen in older female population, rarely seen in males. But nowadays there is an entity of serous cystic neoplasm. It's called the macrocystic variant or oligocystic variant, which is seen in relatively young individual where the mucinous cystic neoplasm comes. So you have to differentiate these two lesions. The mucinous cystic neoplasm usually seen in a 40 to 50-year age group, whereas the main duct IPMN predominantly seen in male individuals. So in fact, the IPMN is the only tumor which is male predominant. All others are female predominant. So incidental pancreatic cyst, when you identify on imaging, you have to look for the cyst morphology, whether the cyst is located in the head, uncinate, body, neck, pancreas, the size of the cyst, whether the cyst is having any communication with the main pancreatic duct, and you have to see whether there is a calcification, because sometimes you will see different types of calcification. You can see some may be associated with pancreatic calcification of chronic pancreatitis. There is a common occurrence of chronic pancreatitis with IPMN, and we are seeing cases now. The other type of calcification which you get in serous cystic neoplasm called the sunburst calcification, and in patients with MCN you may see what you call eggshell calcification. So you may have to look for the worrisome features and high-risk stigmata when you see these type of lesions, and you have to clearly document the pattern of the increase in size on follow-up examination. You will ask this patient to come with the investigation after 6 months, and when will you say there is a growth in the lesion or a significant growth in the lesion? And if you are seeing any multiple lesions, it may be either serous cystic tumor or it may be simple cyst of pancreas, part of adult polycystic disease, or it can be multifocal IPMN, mixed branch duct IPMN. So a cyst less than 10 millimeter, it is difficult to characterize. A cyst 1 to 3 centimeter is actually called the indeterminate cyst, unless you can clearly demonstrate a communication with the main pancreatic duct. A cyst more than or equal to 3 centimeter is classified as oligocystic, microcystic, macrocystic, what sort of description you can. And this is the type of lesion which actually described in different literature as macrocystic, oligocystic, etc. So when you have a main pancreatic duct communication, there are only two possibilities. One is an IPMN, other is a pseudocyst. So for practical purpose, all incidental cysts should be managed as mucinous until proved otherwise. If you have a classical feature of a serous cystic neoplasm, you can leave them. But if you don't have a feature, you have to really investigate those patients. You can use endoscopic ultrasound with FNA broadly when you have a more, when you need a more refined cyst characterization. And you have to have more specific definition of cyst measurement and growth pattern. So this is the growth, which is the significant growth described in literature. For a cyst less than 0.5 centimeter, 100% increase in long axis over a year is considered a significant increase in size. For a cyst more than 0.5 centimeter and less than 1.5 centimeter, 50% increase in the long axis is considered significant. And for cysts more than 1.5 centimeter, 20% increase in size in long axis is significant. So what is the role of major imaging modality? One is for detection, second for characterization, third for assessment for the presence of aggressive behavior, and if you have identified a malignant type of cystic neoplasm, for evaluating the resectability in those tumors. So multi-detector CT is the main investigation utilized in patients with cystic neoplasm. It has got an accuracy of around 56% to 85% in characterizing the lesion. And it is better for lesions more than 3 centimeter, and for a lesser size lesion, you may have to consider other imaging modality. MRI is more sensitive for pancreatic cystic neoplasm. It is superior to multi-detector CT scan in analyzing morphological features, internal septations, mural nodularity, and communication. So it has got high soft tissue resolution and lack of ionizing radiation. But as a surgeon, we are not very used to these sort of MRI images, and we always opt for CT whenever even if you have an MR. So endoscopic ultrasound is the most sensitive investigation for detecting this cystic lesion. It will identify the internal septation, mural nodularity, solid masses, the main pancreatic dilatation, the filling defects in main pancreatic duct, and the probable vascular invasion. So tissue diagnosis is possible by using endoscopic ultrasound guided FNA. Endoscopic ultrasound is utilized as an adjunct to imaging modality, but it is not required in all patients with cystic neoplasm. It is helpful in identifying cysts with features that should be considered for surgical resection. It is recommended if the pancreatic cystic neoplasm has either clinical or radiological features of concern, which is identified during initial investigation. It is imperfect in identifying exact nature of pancreatic cystic neoplasm. You have the contrast enhanced EUS for more clear visualization of these mural nodule. So this is the contrast enhanced EUS. You can clearly see the mural nodule which is seen in the lower images. So if you have a mural nodule on any cystic neoplasm, you have to consider it as significant, and those patients require resection. It actually improves the diagnostic accuracy of pancreatic cystic neoplasm by differentiating mucinous from non-mucinous, benign from malignant, etc. A combined analysis of cyst fluid analysis and cyst fluid lipase level will help to differentiate different types of cysts. EUS should only be performed. I say it's only be performed when the results are expected to change the clinical management. Otherwise, there is no role for doing routine EUS in patients with cystic neoplasm. It should not be performed if the diagnosis is already established by other cross-sectional imaging where there is a clear indication for surgery. So, sending patients for EUS for all cystic lesions is not an accepted reference. So, this is the cyst fluid analysis pattern in different type of cystic lesions. If you have a high CA19N, high CEA, etc., it may be more significant. But a CEA value is more significant than CA19. We have seen more than 1 lakh values in a benign cystic lesions. So CEA more than 192 is considered as significant for identifying cystic neoplasm of mucinous variety like MCN and the IPMN. The nodules seen on EUS, there is a risk of advanced pathology. It is seen in around 3% of branch duct IPMN. But 60% of branch duct IPMN with high-grade dysplasia will have some form of a nodule on EUS. But not all nodules are precancerous. A mural nodule detected on CT has a higher chance of developing or having a malignancy than a mural nodule detected on an EUS because it is only threefold increase. But the drawback of EUS, its invasive complication is around 2.4%, highly operator dependent, and rapid loss of resolution when you have a deeper lesions. There are other emerging methods including the molecular, genetic and fluid biomarker. I am not going into the detail, but basically they can be divided into DNA based biomarker, RNA based biomarker and protein based biomarker. There are different types of biomarker for different lesions. For example, if you have VEGF, it is in serous cystadenoma. If you have GNAS, it is for mucinous cystic neoplasm, IPMN variety. It's very important to differentiate pseudocyst from cystic neoplasm because the treatment is entirely different for a pseudocyst of pancreas. So you'll have a well circumscribed unilocular cyst without any internal septation, with normal serum markers, low viscosity fluid, elevated amylase, and you may have associated malignancy. It's a very critical situation. When you have a patient who is not having any risk factors for pancreatitis and you see a pseudocyst, you have to evaluate for those patients for an underlying malignancy. There may be a small tumor which obstructs the duct, which produces pancreatitis and producing pseudocyst. And it can occur at any location. This is one patient in whom a pseudocyst of pancreas, it was seen inside the liver, inside the spleen, everywhere. So a pseudocyst may be seen everywhere. It can reach even up to the popliteal fossa or even in neck. The most common variant of cystic neoplasm is serous cystic neoplasm, but in surgical series the number of serous cystic neoplasm is less because it is not considered for routine surgery. So it's mostly seen in patients who are elderly, female, and there won't be, most of the time there won't be any pancreatic dilatation or communication, but we have seen patients in symptomatic serous cystadenoma of head of pancreas. We will see dilated pancreatic duct and even obstructed biliary duct. So it is not a dictum that there won't be any dilatation, but we are seeing dilatation. So there are two major variants which I have already told. One is called the microcystic variant, which is the most common type, where you have multiple small cysts which coalesce to form a larger mass. And it is lined by PAS positive glycogen-rich cuboidal epithelium. The macrocystic variant is becoming the differential diagnosis of MCN actually. We'll have larger cyst, but if you have a clear fluid on EUS which is not showing any string sign, you can consider it as a benign lesion. So it will show enhancing wall internal septae, microcystic appearance, you will have lobulated borders. The differential diagnosis will be a neuroendocrine tumor because the numerous small cyst will have good vascularity, and when you see in an imaging, it may show features to which is mix the overlapping features with the neuroendocrine tumors. So a high quality CT will identify the sunburst calcification, the location, the relations with vessels. MRI will show hyperintensity cyst on T2 weighted images. The fluid analysis will show a low CEA, high VEGF level, and the cyst will be lined by glycogen-rich cuboidal epithelium. And you have the patients with von Hippel-Lindau, there is a higher incidence of serous cystic neoplasm. The indications for surgery in serous cystadenoma, all symptomatic serous cystadenoma, patients who are having larger serous cystadenoma of more than 4 centimeter, when you have an uncertain diagnosis, when there is rapid growth on observation and there is a substantial change in radiographic appearance on follow-up. So this is one patient, I was actually talking about the serous cystadenoma of the head of pancreas. You can see IHBR, intrahepatic biliary radical dilatation. You can see pancreatic duct dilatation. So you can see the different types of presentation when you see larger number of cases. The other thing will be, it will have close relationship with the superior mesenteric vein and portal vein. So this is the sagittal view, and you can see a larger lesion. And we have adherence to the vessels. We have difficulty in separating the vessel, but there is no infiltration. Finally, we could resect the lesion. You can see the dilated bile duct and dilated pancreatic duct. So this is in nutshell about serous cystadenoma. It's a benign disease. The malignant transformation is very less, only less than 50 cases reported in world literature. So you can observe unless there is symptoms or rapid increase in size. The most important variant is the mucin producing cystic neoplasm. You have two variants. One is the MCN and other is the intraductal papillary mucinous neoplasm. Both are pre-malignant condition, and if you identify at any some point of time, you have to consider surgery. So mucinous cystadenoma is more commonly seen in women, more than 90%. I have seen only in one male patient. Asymptomatic vague presentation, you may see some large abdominal mass, and 6 to 48% of asymptomatic lesion can harbor cancer. The cross-sectional imaging will help you to identify the type of cyst, the macrocyst nature, septations, mural nodule, etc. So it will have a round, thick-walled septated cyst, no pancreatic duct communication, and based on the epithelial dysplasia, you can divide into adenoma, borderline, and carcinoma. The imaging will show a unilocular or a septated or a macrocystic lesion, and there will be curvilinear or linear or curvilinear septations and peripheral eggshell calcification. If you have identified a calcification of eggshell type, it actually have a predictability of malignancy. So there is a higher chance of malignancy. So the presence of thick enhancing septation or mural nodule, you have to consider malignant transformation. So there is no point in observing these lesions. Cyst fluid analysis will show a mucin-rich fluid, then string-sign will be seen. It's very difficult to separate. It will be posicellular, and a cyst fluid CEA more than 192 is suggestive of, it has got a 73% sensitivity and 84% specificity for identifying MCM. So you will have a KRAS mutation when there is a malignant transformation, and GNAS mutation is not seen in MCM. So this is the appearance of MCM on the MR, and you can see the different types of lesion. It has got some features like hydatid cyst, but it's not having any classical feature of like the hydatid sand or other thing. So the treatment, you have to do surgical resection depending upon the location. If it's in the head of pancreas, you have to do a Whipple's resection. In the tail body region, you have to do distal pancreatectomy. So you may have to consider adjacent organ resection, because a resection carries a good prognosis, and the 5-year survival will be good if you have a margin-free resection, margin-negative resection. So you have to follow up these patients. Some of these patients will develop recurrence at a later date, and you have to do imaging whenever there is a symptom. So this is about MCN, mostly seen in a middle-aged individual. So intraductal papillary neoplasm is the second variant of IPMN. When we learned in the early phase, I have not seen any cases, but nowadays we are seeing all type of IPMN, branch duct, main duct, IPMN with carcinoma, all type of IPMN now. So mostly seen in men rather than female, but our population is more commonly seen in female again. So you have 3 types. One is called the main duct type. It is characterized by pancreatic duct dilatation of more than 5 millimeter. Branch duct type, you will have multifocal cyst with clusters, grape-like clusters with or mild or no dilatation of main pancreatic duct. If you have a lesion of dilated pancreatic duct with a smaller peripheral lesion, you will consider as mixed type. For main type and mixed type, the malignant transformation is higher. Branch type, smaller size lesion, you can actually follow up. So MRI will give more accurate diagnosis than CT, because it will identify the ductal characteristics, ductal communication, the soft tissues, the mural nodule, etc. better than a CT. So MRI is a preferred investigation for diagnosing IPMN, especially of the main duct variety. The fluid will show high CEA, and you have 4 distinct histologic type, of which the oncocytic variant has got the best prognosis and pancreatobiliary has got the poorest prognosis. So when you see IPMN, you have to consider whether there is a high risk feature or whether you have an borisome feature. The high risk feature include main pancreatic dilatation more than or equal to 10 millimeter. Patient is having obstructive jaundice and cysts in the head of pancreas. When you have a solid mass or the cancer of or higher grade dysplasia on cytology or mural nodule of more than or equal to 5 mm. The borisome feature include main pancreatic dilatation between 5 to 9 millimeter, cysts of more than or equal to 3 centimeter when there is a lymphadenopathy, elevated carbohydrate antigen more than 37, mural nodule of less than 5 mm, cyst growth more than or equal to 5 mm per 2 year, and change in caliber of main pancreatic duct, and you have a thickened or enhancing cyst wall, and new onset diabetes. All these are worrisome features in patient with IPMN. The prognosis of IPMN carcinoma is different when you have a T1 lesion, but if the T2 to T4 and N1 lesion has got almost the same prognosis. But the problem for IPMN carcinoma, sometimes you may have to consider total pancreatectomy. So carcinoma arising in intestinal and oncocytic variant has got a better outcome. They all form a colloid type of carcinoma compared to gastric and pancreatobiliary type. They form a tubular type of carcinoma. So these are the imaging picture. It is more related to fish. You have the fish mouth appearance, and when you see pancreatoscopy, you will see some fish egg appearance inside the pancreatic duct. So these are the picture suggesting of IPM. You have dilated pancreatic duct, irregularly dilated pancreatic duct with the presence of thick mucin. You have the fish mouth appearance and EUS showing the mural nodule and a dilated PD on resection. So malignancy in main duct IPMN, it is to the tune of around 43% of invasive malignancy and 70% of high-grade dysplasia or carcinoma in situ. So when you have a diagnosis of main duct IPMN, you have to consider surgical resection because the chance of developing an advanced malignancy on follow-up is high. But in branch duct IPMN, the chances of malignancy is only around 25%, and the size of the lesion has got some relationship with development of malignancy. A lesion less than 3 centimeter, chance of harboring a malignancy is very less. So the main duct IPMN treatment option is surgical resection depending upon the location, but most of the time the lesion will be in the head of pancreas. You will have to consider Whipple's resection. The rationale for resection include to ameliorate symptoms, to remove high-risk lesions, to potentially cure invasive lesions, and sometimes you can have an observational approach, especially when you see diagnosis in an elderly individual where a total pancreatectomy carries a very high risk of mortality, then you can actually observe. In low-risk patient with main duct IPMN, there is no, there is no immediate reason for resection, you can always observe. So the indications for surgery in IPMN, absolute indication, positive cytology for malignancy or high-grade dysplasia, a solid mass, obstructive jaundice related to the tumor, enhancing mural nodule and main pancreatic duct dilatation more than 10 mm. The relative indications include the increasing size more than 5 mm per year, increased levels of CA19N, main pancreatic duct dilatation 5 to 9.9 mm, cyst diameter of more than 40 mm. So up to 30, there is no high risk. New onset diabetes mellitus, acute pancreatitis caused by IPMN and enhancing mural nodule. All these are indications for doing surgery in IPMN. The method of resection is different from other type of cyst. Most of the time it's very challenging because you cannot stop at some point because you will see the lesions going from head towards the tail. Sometimes you will not have any cancer or anything after resection. So you have to convince the patient's bystander after resection because you have done a total pancreatectomy for a benign disease which can actually be observed in some cases. So it has to be individualized, and you have to do something known as the creeping pancreatic resection. What that means, you will cut pancreas, look for the dysplasia. If there is high-grade dysplasia or invasive carcinoma, you have to resect more, amounting to a total pancreatectomy. But if there is low-grade dysplasia, you can stop at that point and you can observe this patient. It is said that if you do Whipple's resection for IPMN, it's better to do anastomosis with the stomach because you can actually analyze the pancreatic duct through the gastroscopy. But if you have done a classical reconstruction of pancreatic duct into a jejunum, it's difficult to assess using an endoscope. A standard lymphadenectomy has to be part of all patients with IPMN resections. The role of frozen section, because most of the time you may have high-grade dysplasia in one point, the dysplasia in the other point may not be high-grade. So you have to consider resection depending upon the frozen section results. So this is in nutshell about IPMN management. If you have a main duct IPMN, most of the time you have to consider surgery. The only factor consider as the advanced age of the disease and other comorbidities. But if it's a young patient, it's always better to advise surgery in main duct IPMN. So surveillance after resection of main duct IPMN, if the initial surgery there is only low-grade dysplasia, the surgical margin is negative, you have to do CT second and 5 years after operation. If it is positive, you have to do it every 6 months. But if there is a high-grade dysplasia, you have to do MRI or CT every 3 to 6 months. And if you have invasive carcinoma, it has to be every 3 months. So it's a very hectic surveillance recommended as per the literature, but we cannot do this type of imaging modality in our institution. The next variant, actually this is the most common type of cystic neoplasm in surgical literature nowadays, especially in India. The solid pseudopapillary epithelial neoplasm. Just now you saw a resection by Dr. Shailesh. It's described by France. It's otherwise called a Hamodi tumor and other different names. It's classically seen in young individual. I have seen only one patient with SPEN in a male patient. All others were female and mostly seen in young age group. The youngest patient I operated was 9 years old and the oldest patient I operated was 48 years old. Pseudopapillary epithelial neoplasm, it has got uncertain malignant potential. In my practice, I think all are malignant type because the metastasis and all, only when you see a liver met or a lymph node met, you can say it is cancer. Otherwise, all the tumor will have almost the same pictures, even on histology as well. So it may be the perineural invasion or angio invasion or adjacent tissue invasion. It's one of the most difficult tumor to do surgery because most of the time the vessels will be adherent. There will be an inflammatory reaction which is very difficult to differentiate from actual tumor invasion. So this is one patient, 21 years old, newly married. Patient had a lesion detected on CT and you can see a metastatic lesion in the liver as well. So this happened during the COVID time. So I had to do a Whipple's resection. When I opened, I didn't see any branches of celiac axis. No hepatic artery, no left gastric, no splenic, nothing was there. I could see only the portal vein. But I did a Whipple's resection without having any intrahepatic arterial vasculature. And I left this patient for follow-up, for doing the liver resection at a later date. Patient actually came after 3 months with a very extensive fatty liver. And the liver metastases were persisting. And they went to outside center from where they did liver resection. After that, she conceived and now she is having no health issues. So, even if you have liver metastasis, even if you have a very large tumor, even if it amounts to a major vascular resection, it is always advised to consider surgery in patients with SPEN because their life expectancy is much higher than other type of tumors. So, when you have an MRI taken, it will have different type of appearance because of the tumor necrosis. It will be having a cystic pattern or a solid pattern or a heterogenic pattern. This is another patient. She was pregnant 6 months. You can see the pregnant uterus. You have a large cystic lesion because in pregnancy the size of the lesion tend to increase in size. There will be some hemorrhage and all. So I had to consider surgery still with the child inside, the fetus inside the uterus. I did a distal pancreatectomy and splenectomy. Nothing happened. The child is around 6 years now. So cystic neoplasm usually occurs in, the SPEN usually occurs in that age group only. So this is another patient done in 2016. A large lesion, Dr. Jayan was assisting me during this procedure. A large lesion in the head of pancreas which is actually almost compressing and just like an infiltration seen in the portal vein superior mesenteric conference. So if you are interested, I will show the video, otherwise I will skip and go. So I can actually. So you can see the large lesion with. Some of you might have seen this video if you have attended the liver or the surgeon's club, gastro club. So you can see a large lesion in the head of pancreas with increased vascularity in the cystic area, with dense adhesion of the lesion to the superior mesenteric vein. Actually, superior mesenteric vein was not identifiable on initial trial dissection. So, what I thought superior mesenteric vein was actually the inferior mesenteric vein. So, I had to really dissect, go in between these vascular area to identify the, you can see the superior mesenteric vein coming into view. So one of the interesting point which I find is when you have the enlaced trunk, the right gastroepiploic and the accessory right colic trunk identified, and you ligated, it's easy to dissect the tumor from the superior mesenteric vein. But if that is difficult, I think you will end up with a very torrential bleeding and all. So now we have dissected that entire area. Still the tumor is adherent to the portal vein, superior mesenteric. Actually, this is a superior mesenteric vein. The lesion is in the uncinate process. One of the most difficult location to do resections. This patient actually having a 1-year-old child, did at the age of 22 years, and I was in a very tensed situation because she's having a very small kid. The surgery is having very difficulty because of the adherence to this vessel, and I got the help of Dr. Jayan. Dr. Jayan is here now. So he stood with a great mentor-like character during the surgery. So I could identify that was the right gastroepiploid, joining the superior mesenteric vein. It's the enlaced trunk. If you can dissect this, actually you can dissect the superior mesenteric vein. The interesting problem with the SPEN is that it will not dilate pancreatic duct. It will not dilate bile duct. Most of the time after Whipple's resection for SPEN, we will find bile duct leak rather than a pancreatic leak, because we have to do anastomosis in a very small bile duct, around 5 millimeter bile duct. Now you can see the superior mesenteric vein is getting bulging because we have separated it from the, there was a pseudo-capsule-like thing because of some inflammation. And if you have a diagnosis of SPEN on CT, there is no point in doing a EUSFNA. Because if you do EUSFNA, what happens is this area will become some inflamed area, and the separation of the lesion from the adjacent vessel will become very difficult. So what happens is patient will have some tumor left behind in that area, and that will land up in a what you call a R1 type of resections. So during surgery there was some major bleeding from the superior mesenteric vein, but we could control it without any vascular instrument, because there is no space for applying the vascular clamp. The assistant's hand was the vascular clamp during the entire procedure. So what you need during this time is patience and a good assistance. So now I am lacking both the assistance and patience because of so many reasons. So I don't think I will do a surgery now because it's very difficult at this age to have a major resection like this without doing portal vein resection. You can do it with resecting the portal vein. The problem of resecting portal vein in this type of tumor is that you are doing surgery in a very young individual. So whatever graft you use for portal vein reconstruction, all of them will undergo thrombosis and you will have extensive collateral formation. I have 2 or 3 patients who underwent surgery in their childhood from pediatric surgery department elsewhere, and now they all came with a recurrent lesion with extensive collateral. So now I cannot do any surgical cure for that tumor. But if there is no collateral, we can actually think of doing re-resection and all, because the long-term survival is very good. Finally, we have actually reached the last part. Okay. So still there is more bleeding. And you can see the artery, actually that is the inferior pancreatic duodenal artery. It was actually become the size of a hepatic artery or a very major vessel because of the large tumor size. So now the tumor is almost completely separated from the area, and I did a transection of the pancreatic neck and proceeded with completing the Whipple's procedure. And you can see the pancreatic neck is transected. Actually the portal vein was not affected, only the superior mesenteric vein was affected. And finally we got an area like this, so without any further damage to the other area. So you can see the superior mesenteric vein, portal vein, inferior mesenteric entry, etc. But to reach that level is very tiring. So solid pseudopapillary epithelial neoplasm is seen in younger individual. More than 90% occurs at the age of 21, located throughout the pancreas. And the resection most of the time is very difficult because of the large size. So the other entity is cystic neuroendocrine pancreatic endocrine neoplasia, seen in 8% of cystic tumors and 10 to 17% of resected pancreatic neuroendocrine tumors. They are all mostly incidental and non-functional, and you will have some, the CT will show some enhancing wall with a cyst-like lesion. There will be high cellular yield. Compared to other type of cyst, you will have low cellular yield, but neuroendocrine tumor, you will have high cellular yield with low CEA. So this is another patient. Actually, she came immediately after delivery, a young girl, a large lesion in the talopancreas. I thought it is solid pseudopapillary neoplasm, so I suggested surgery. So because of younger age, I said you go for a second opinion. And they went for a second opinion, and I didn't see her. And after 2.5 years, her husband came to my house and said, came with the CT. He didn't know me because first time she came with her father. So when I saw the CT, I said, I have seen this CT around 3 years back. Then he said they went for a homeo treatment. That was the second opinion they sought. And this fellow treated this girl for 2.5 years. When she developed skeletal metastasis, he said, now you can go to the original doctor and they will treat the patient. I think she might be died. No? by that time. So this is cystic neuroendocrine neoplasm. The final HPR is cystic neuroendocrine neoplasm. The lymphoepithelial cyst is another variety, but you don't require any treatment for these type of lesions because most of the time they won't develop any tumor. And one surgery is cystogeganostomy indicated for lymphoepithelial cyst, but most of the time we won't do any resection. So the surgical approaches can be open, laparoscopic or robotic. Distal pancreatectomy you have seen. You can have pancreatoduodenectomy. You can have total pancreatectomy. There are organ preserving approaches like enucleation, central pancreatectomy, spleen preserving pancreatectomy, and duodenal preserving pancreatic head resection, etc. So enucleation you may consider for small IPMN, the branch duct type of lesions. Median pancreatectomy is one surgery we do, especially for SPEN or serous cystic neoplasm. This girl actually postpartum identified a lesion in the neck of pancreas. So we resected the neck, the body anastomosed to the Roux-en-Y limb of jejunum. This is one patient who had a serous cystadenoma with symptoms. You can see dilated pancreatic duct again. So we did a resection of the duodenal, the resection of the tumor without resecting the tumor. You can see the portal vein superior mesentery coin confluence and the resected tumor. The middle preserving pancreatectomy is done especially when you have multiple cysts. This is done in branch duct IPMN when you have multiple lesions in the head and tail region. You preserve only the tail. So there are different guidelines for different societies have different guidelines, and they all suggest surgery in different ways. But what we have to say is you see your patient as an individual and don't go by the guidelines. Then you get good results. So this is the management algorithm, cystic lesions of the pancreas. If it is unilocular, you have pancreatitis, consider pseudocyst. There is no pancreatitis, normal amylase, consider alternative diagnosis. Asymptomatic management depends upon several factors. Symptomatic surgery or cyst aspiration. Serous cystadenoma, asymptomatic, you can follow up. It is symptomatic, go for surgery. Malignant neoplasm, you go for surgery. Mucinous cystadenoma or IPMN, you have to have, if you have a dilated main pancreatic duct and symptomatic, go for surgery. Asymptomatic management depends upon several factors. These several factors include the age, comorbidities, etc. So incidental pancreatic cyst is seen in around 1.2% of cases, and prevalence is likely to increase because the incidence of MR imaging is increased because it's available everywhere. Nowadays there is a decreasing trend for US and an increasing trend for MRI, which we are seeing. So you have to really look for whether it's a cystic neoplasm, could this lesion be malignant or harbor malignant potential, or does it need to be resected. So this is the algorithm. If you have a unilocular cyst more than 3 centimeter, go for surgery. Less than 3 centimeter, benign pattern observation. More than 3 centimeter, you go for surgery. So that 3 centimeter is the criteria put forward by most of the guidelines. So if you have a microcystic, most of the time you can observe. Macrocystic, you have to look for the behavior. Then if you have mucinous variety, you go for surgery. Non-mucinous, you can observe. And mixed, you go for surgery. So this is the surveillance approach. I think you don't follow these approaches. So it's our data till 2022 July. We have operated around 117 pancreatic cystic neoplasm. We have added 21 cases more, of which majority of them was MCN or SPEN. So we have done around 21 Whipple's. Now we have done 26 Whipple's procedure for SPEN alone. So our data is, this is only for cystic neoplasm, and we have done one total pancreatectomy for MCN and one total pancreatectomy for IPMN. So the take-home message is cystic neoplasm of pancreas varies widely in clinical behavior. And thorough clinical history and examination will help to differentiate pseudocyst from cystic neoplasm. And EU is a valuable adjunct in the management, but you have to use it wisely. Unnecessary resection should be avoided if possible, and if surgery is needed, consider organ preserving approaches whenever feasible. Thank you.
Thank you, Dr. Prathapan. That was a great, simple yet comprehensive presentation. Discussion.
I think you have done a detailed description about all the cystic neoplasms of the pancreas. Thank you. Now, I think among the types of these, the different types of neoplasms, neoplasms, cystic neoplasms of the pancreas, SPEN seems to be a easier one. We had some years back, I know this, we had done a surgery for a SPEN. It was in the tail of the pancreas, and it was in a female patient, younger patient, and the dissection was somewhat easier, I would say, like that. And probably I don't know, would be earlier one, not a malignant one, and that easily could be resected. And again, it is in the tail of the pancreas, and that you can do at least a distal pancreatectomy and come out of these problems. So it's not difficult. If it were in the head or the body, it could have been rather difficult. The one that you showed in the video is somewhere in the middle of the pancreas or
Head of pancreas.
Head of the pancreas. So probably there you will get a lot of problems. So usually this SPEN is in the tail of the pancreas.
No, I think the distribution is equal. Because in our data, actually 50% is in the, almost 50% in the head of pancreas. I don't think, because maybe the referral bias, the peripheral centers will do all the easy one, and the difficult ones will go to the centers. Because the Whipple's resection is costlier outside. A distal pancreatectomy is less costly, you know. And it's easy and less complicated.
Less complicated. And that patient had a good survival also. She lived for a long time.
Most of these patients survived, except one or two patients who had a major. One patient, when I opened the superior hepatic artery and the portal vein, was completely gone.
The one that you showed.
That's not that. That is not that case. So when I transected the pancreatic neck, the extensive collaterals, and there was bleeding from everywhere. I could not stop. That was the only patient where I failed in the OT for controlling the bleed. Somehow I stopped the procedure and put clamps on that area, thinking that patient is not going to survive. On table, death avoided, but sometimes whenever you have a large lesion, when the portal vein and superior mesenteric vein is gone, even distal pancreatectomy can be very difficult because there will be extensive collaterals in that area.
So age-wise also it is very interesting as far as the cystic neoplasm of the pancreas is concerned. So in a grandmother, mother, and then daughter. Grandmother it is cirrhosis, then it is mucinous neoplasm in mother, and daughter it is SPEN.
Granddaughter.
Granddaughter.
Okay.
Granddaughter it is SPEN. So what about the polycystic disease of the pancreas? Is it along with what is the incidence?
No, polycystic disease. I have seen only 2 cases. The problem is when you plan surgery, it has to be a total pancreatectomy. We don't know the prognosis. But von Hippel-Lindau disease, you can have both. Sometimes you will see neuroendocrine tumor along with multiple cysts in the pancreas. I have operated one girl. Actually, she underwent her brain tumor surgery earlier and developed a tumor in the kidney as well as tumor in the head of pancreas.
Thank you.
As usual, very excellent presentation. And I consider Pradhan as I was in HOD surgery, the extension of surgery department. He was always helpful for us operating these sort of cases also. And usually he visit the theater while he was operating, and he comments some interesting comment also. Is the X-ray of CT, when I was operating cirrhosis adenoma and Whipple, he commented that this only cirrhosis operation avashyamillairunnu. Now the slide shows that more than 4 centimeter, you should operate. That patient was more than centimeter. And with abdominal pain and occasional jaundice, patient is still surviving. Like that, it's always helpful. And one question, main pancreatic duct and branch pancreatic duct, IPMN. Why should differentiate these too much? Any advantage you differentiate in main pancreatic duct IPMN?
Two things. The malignant potential of the side branch lesion, because pancreatic duct has got the main connection with this smaller branch. Whenever there is ductal communication, you call it as IPMN. Okay, the smaller duct communicating lesions has got a lesser malignant potential compared to main pancreatic duct lesions.
The question is, peroperatively, microcysts are there. How will you differentiate? How will you identify the cyst?
Microcyst usually occurs as a part of serous cystadenoma. In IPMN, you just enucleate it. Nothing will happen. You just close the duct which connect to that. There are two areas where you can actually do enucleation. One is serous cystadenoma, other is branch duct IPMN of smaller size. If there is distance from the main pancreatic duct is away, you can do enucleation.
Thank you. One more point, that is, you should thought the anastomos to the stomach is a surgeon choice, but you are present it's a for the point for the BGs. It is not the surgeon choice. If it is IPMN, better to stomach. Thank you.
Serous cystadenoma, stellate.
Is it suggestive of malignancy?
No. It's an eggshell calcification suggestive of malignancy. That's in MCN.
Well, I thought that the stellate scar and read somewhere.
That's scar tissue you get in serous cystadenoma.
Good presentation. I have only one doubt, that is, you have mentioned about the serous cystadenoma as a size criteria. 4 centimeter more than 4 centimeter you have to operate. Is it a?
It's an old criteria. But the problem is, if the size of the lesion is 4 centimeter and the patient is symptomatic.
Symptomatic you have to operate.
Okay.
No doubt.
If it is in the head of pancreas and it's very close to the major vessels, we conveniently say you don't require any surgery. Yes. But if the very easy position like distal pancreas, yes, etc., you can. By this selection
4
criteria,
centimeter, more than 4 centimeter serous cystadenoma in the body and tail, you can resect, but in head,
observe. That is the criteria followed. Because of the complexity of surgery, we are not doing surgery. Now there are endoscopic ultrasound guided ablation of the mucinous cystic neoplasm. The gastroenterologists are taking this cyst into their area. So I don't think.
I have two questions, sir. In our setup, getting a US done is very difficult. So preoperatively, is US mandatory?
No.
Not at all.
I have clearly said, if your CT or your imaging suggests a surgery, you need a surgery, the lesion is likely to benefit from surgery, then go for it without doing FNA.
So my second question is, if you are keeping a patient for non-operative management, maybe a 3 centimeter or 4 centimeter, then US is mandatory.
No, if the size is less than 1 centimeter, US will not help.
Not for 3 centimeter.
If it is 1 to 3 centimeter, you may consider US. But for practical purpose, all these incidental cyst has to be considered as mucinous, and you wait. The 3 centimeter, the chances of developing malignancy is less unless there is a ductal communication. A peripherally seen a 3 centimeter cyst in a pancreas, chances of harboring malignancy is very low. But if it has got a communication, that will carry a higher risk. So ductal communication is the key in identifying this. If you do MRI, that will actually identify the ductal communication.
I was very happy to see your case bleeding because I never saw you bleeding. This time I'm very happy.
I wanted to show you how it bleeds.
I have two things. I want to ask one question, Shailesh sir. Two spectrum of cases was there. One was very, I think the lab was very easy procedure. Maybe your expertise. So will you always choose lab for all the cases, or you selectively attempt lab in everything, or you are very choosy about selecting patient for laparoscopy?
It is only by selection. If it is a large lesion, we will definitely will not consider lab. Thing is that it is said that up to 10 centimeter you can go by laparoscopy. More than 10, it's always better to do open, especially in the case of distal lesions. That is, yes, up to 10 centimeter you can. It is benefit. It is a beneficial to laparoscopy. That's mainly because you need a incision for specimen extraction and all. So 10 centimeter incision.
Most of the time, the issue is it occurs in a young age individual.
So anyway,
Unmarried.
patients, everybody will prefer laparoscopy. So advantage of this thing is even if it's a larger than 10 centimeter, you can even attempt by laparoscopy because the incision you can make from in a phalangeal incision. Usually, if it is a small lesion, we will take it out by extending the umbilical port. If it's a larger than 5 centimeter or 7, 8 centimeter lesion, we usually take it by a phalangeal incision. So you can convert a upper abdominal incision to the lower abdominal incision. So when size increases, it's always difficulty is more. There's a more chance of spleen also we have to be resected because it is an easier procedure. We have to, these vessels we can ligate, then procedure becomes easy.
Nowadays, we are seeing Castleman disease in pancreas. Surgical oncologists are sitting in the back. Castleman disease mimicking cystic neoplasm. I have seen 3 or 4 cases of recently one patient. Any Divak? Castleman disease. Actually, it may be in the node, but may present like a lesion in the pancreas. So CT they had reported as pancreatic lesion, and finally we opened, it was only a lymph node lesion. CT will not help. You have to do a homework. Today I will do surgery. I will resect without any major event. That you have to take in your mind. Otherwise, it's difficult because most of the span of larger size, it is very difficult to separate in some area. The main area is the Henle's limb area, and it is very difficult when the lesion is in the uncinate process. Because otherwise the lesion can have, you can just give away, move away from the main portal. Uncinate process, the vessels are very close and the lesion will be very adherent. But seeing the literature, what I feel is doing resection like this can actually produce recurrence in the later life. But I operated this patient in 2015. Last month I did a CT. As around 8 years, she was having some diarrhea. Because of this extensive resection in that area, she developed some IBS-like symptoms because the nerves are gone when you dissect like this. That's a basic problem. I think if you have a small infiltration or you can graft it with a endogenous or like a renal vein or internal jugular, it's okay. But keeping the graft, especially when you have a longer lesion, invariably you have to consider the graft like Tacron, PTF, etc. Invariably they will develop thrombus, obstruct, etc. As far as possible, consider keeping the natural superior mesenteric vein and portal vein.
Vein will be plastered to the, there is no infiltration, there will not be an infiltration, but it will be very tightly plastered because of this large lesion. So in such cases, it's very difficult. The only thing, good point is if you can go both sides of the vein, like in the lower part SMV and upper part portal vein, you get a loop around there, then you can clamp it and then you can cut close to the vein. That is the only thing that we do. And then after that, you can release the clamp and on the bleeding points, you can switch up. That is the thing to do. But in some cases, it will be possible.
If there is collaterals inside the gland, pancreas, it's very difficult. Even it can bleed when you transect the neck. That's a problem. I think you have to take your breakfast, good breakfast and good assistance. Otherwise, this sort of surgery actually burn your hand.
If there are no more questions, we'll close the session. I request Govi sir to hand over the certificate to Pradhavan sir. Sir. I request Rajan sir to hand over the certificate to Shailesh sir. Request Nirmal sir to hand over the certificate to Dr. Naveen. There is one important thing. We are organizing the Calicut which falls on May 10, 11, 12. I think you will be trusted with our paid promotion by our SPDH team. You will be receiving messages on and off. Kindly consider registering at the earliest. And kindly I request all to participate for the Calicut. For the vote of thanks, I don't need special vote of thanks to Dr. Pradhavan sir because I just told when I was going to the SOT sir, nala presentation, okay le. Sir told okay. And I think Shailesh sir I disturbed in the last minute. He was not so sure about conducting the meeting, so I asked him at the last minute. And he readily agreed within maybe one day, he told, thank you sir. And thank you Naveena. And last but not least, I would like to thank, in spite of a heavy sponsorship for Calicut, the Sun team has done, Solitus division has done for us. And from their side, I am requesting that their brand product is Sompras L. It is not Sompras D or plain Sompras. They are specifically asking for Sompras L. So if you are writing a Sompras, just write a L added to it. They are our main sponsors. Thank you, Sun division. The meeting is urgent. I think you can have the. Thank you.